Okay, we are just after 1 o'clock, so I will start the meeting if that's okay. Firstly, to say we have apologies from our chairman, David Flory, this afternoon, so I will be chairing the meeting. For those of you that don't know me, my name's Roy Fisher. I'm the Vice Chairman of the Strategic Commissioning Committee, but also the Chairman of Blackpool CCG. And again, for your information, this afternoon, the meeting is being recorded on Microsoft Teams. It is not being live streamed, but the meeting recording will be uploaded to the Lancashire and South Cumbria Health and Care Partnership website following this meeting. Meeting papers have been published on the website, so any member of the public can access them. And when a member of the public registers to attend this meeting, they are sent a link to join this meeting. So appropriately at this juncture, I shall welcome members of the public. I'm very pleased to have you with us this afternoon. This is a meeting held in public, as I think we know. So the meeting is held in public and therefore will be subject to discussion amongst the members, but unfortunately members of the public cannot join in that. And the chat room is a part of this meeting, so therefore it's a preserve of the members of this meeting as well. So therefore we have a lot of important issues on the meeting this afternoon to deal with. And so again, I'd like to welcome everybody. We've had those introductions, so I shall move on to the agenda and shall move on to item 2, which is apologies for absence. We do have a number of apologies and a couple of late apologies, so we have people who are substituting for people who've apologised. So if I could ask Sandra to go through those apologies for me, that would be helpful. Thanks, Sandra.
Yeah, we've got apologies from David Flory, Jane Scattergood, Debbie Corcoran, Beth Goodman, Paul Kingham's going to represent Beth, Adam Jandua and Kevin Toole's here to represent Adam, and Linda Riley with Stephen Newton to represent Linda.
Okay, thank you for that, Sandra. And is anybody aware of any other apologies verbally that Sandra's not indicated? If not, okay, so thank you for that again, Sandra. So move back to the agenda, and I should say welcome to the people who are deputising again this afternoon. So we have item 3, declarations of interest relating to any items on the agenda. I've not been made aware of any declarations of interest other than the ones that people have already indicated. So if there's no additional declaration of interest, we'll take those as being the ones that people have already responded to in the past. But if there are declarations of interest that might come up as a result of discussions during the meeting, could please colleagues indicate so that those are correctly put in the minutes. So again, if it's an item that comes up that people feel they do have an interest in, please indicate that at the time and we'll ensure that's included in the minutes. So at item 4, we have the minutes of the previous meeting that was held on the 15th of July. Those have been circulated with the agenda. They're before us this afternoon for our agreement, unless there's any changes anyone who makes material changes to those. Are we happy to agree those, colleagues? Can I have your agreement? Yes. Okay.
Yes, thank you,
I
Chair.
have somebody just formally second those. Graham, could you formally second those? Yeah. Okay, that's fine. Thank you. Those are formally seconded. So again, we move on to item 4, I think, which is the formal action log. And there's just one item on there, and that was about the new hospitals programme case for change. We had a discrepancy in the version that was brought to us, and that's been corrected in the final published version, unless anybody wants to add anything to that particular action. Can't see anyone indicated at the present time, so I'm going to again move us along, if that's okay with everybody. Okay, thank you. So I shall move to item, I think we're on item 5, are we on the agenda? Discuss the minutes, we've discussed the actions and the matters arising, so therefore we're at item 5, which is key messages, and that's Andrew. So Andrew, got key messages from yourself. Thank you.
Thank you, Chair. We tend to use this part of the meeting just to perhaps record a number of national or local activities that are taking place that set a context for some of the agenda items, and it's not difficult to choose items to perhaps emphasise at this point of the meeting. Clearly, the NHS now moving into towards the second half of the financial year, moving into the autumn, of course, and it's obvious that we still have a number of very significant challenges in terms of our response to the COVID pandemic, and then the additional actions that relate to recovery and restoration of services and service performance and quality, because of the levels of disruption that we have faced in the last 18 months or so. So it's perhaps useful to say how grateful we are to those colleagues that are leading on that work. It usually means we have people working locally in their organisations. They might be working in their local partnerships, but many of our senior leaders and clinicians are working across the Lancashire and South Cumbria system too. And so you'll get a sense of that, colleagues, as we work through different sections of the agenda today. Because we're moving towards the second part of the year, we're also moving to the what we're calling H2, second half of the year for planning. And that links up to some of the national statements that were coming through the Prime Minister over the course of this week about the financial settlement for the NHS and social care. In broad terms, we obviously welcome clarity in relation to the financial settlement. There's more detail to come out to us to understand exactly what some of those assumptions are that are being made and what that means for us in local terms. And so again, between now and our next meeting, we expect further national planning guidance, which we'll need to work on in detail, and we'll obviously be using a range of our groups, including the SCC, to report on progress. We have important work still to do in our system around recovering our long-term financial stability. We've touched on that in the past, and again, I will give the assurance that we are moving work through on that and can report on that in future meetings as well. But in addition to those service and frontline challenges, colleagues also aware that before the summer recess of Parliament, the second reading of the Health and Care Bill was approved. And as MPs have returned to the Commons now, they've moved into the committee stages of scrutinising the legislation, through which we'll create new integrated care structures and governance and accountabilities across the country. So that process is also moving. That will inevitably lead to the end of CCGs at the end of March, and that's why the paper on CCG close down is on our agenda today. The creation of new structures across Lancashire and South Cumbria, and also in our place-based partnerships. For our future meetings, we're likely to include a glossary of terms, because one of the implications of the legislation is some changes in the way that we're using some of our jargon, and I think we want to be talking about some of these issues very clearly, knowing that we're meeting in public and we need to be exact about our integrated care arrangements. So we will pick that up, and it leads to changes in structures and leadership, which are the subject of national recruitment processes now. So pleased to confirm that David Flory, our independent chair, has been appointed as the chair designate for the Integrated Care Board, and the role of chief officer is out to a national external process. Whilst all of that is taking place, we remain concerned for our members of staff who have worked incredibly hard and continue to do so, whatever their roles, to try to keep services developing, improving, recovering, and to also go through the planning arrangements for the future. And I need to pay tribute to those colleagues, Chair, because this is a significant period for us, and we can expect that will continue right through the winter. And so that would be the key messages for today. I hope it provides a little bit of extra introduction to some of our items today, and happy to take any questions if there are any. Thank you, Chair.
Okay, thank you, Andrew. Very clear on those messages. As you've already indicated, a number of the points that you've made there will be discussed further on the agenda this afternoon. So I will take any comments, questions from colleagues if they have anything to raise with Andrew on those messages that he's brought to us. If not, and if you're happy to move on, I shall move us on. Okay, thank you very much. Thank you, Andrew, again. I think it's you again. We're on item 6, which is terms of reference. These are here for approval this afternoon. I think I had 2 cover sheets to cover these. So I think one's about the terms of reference now and proposed terms of reference for the future. Are they, Andrew? If you could just clarify that for us, thank you. I'll bring those for approval later. Thank you.
Sure. Thank you again, Roy. So this is just a piece of appropriate diligence work around the terms of reference for this committee. Colleagues, remember that we revised the purpose of this committee earlier in 2021, and our CCG governing bodies approved the role and remit of this committee. But there have been a number of changes as a result of changes in leadership, particularly Amanda Doyle's appointment to the role of Regional Director. And so colleagues have re-examined the terms of reference, particularly in relation to the membership of this committee and the voting arrangements for members. And we just wanted to bring that through to you today. Just to be precise, again, in the past and now, with me acting as the Chief Officer for the ICS, I'm also the Interim Accountable Officer for 3 CCGs. But when I come into this meeting from a voting perspective, I will just vote in the role of ICS Chief Officer, as has been previous custom. And we have senior representatives from the 3 CCGs who join the rest of you in the voting arrangements set out in section 7.2. So we've particularly paid some attention to that, so that it deals with these interim arrangements. It is consistent with the previous approach that we've taken in the SCC, but this allows us to be very clear and updated with the terms of reference. So again, I think there's just one cover sheet, if I'm right, just to confirm this, that Becky has drafted, Roy. But again, hopefully this is a clear revision and people are content to support it.
Thank you again, Andrew. There was an Excel spreadsheet, I think, sent with this particular paper that covers the membership of this committee. I think what you've said there is absolutely right. I think there's a certain amount of fluidity about the membership of this committee, and things may well change over the forthcoming months. So I think this may be something we might have to revisit again at some future date, but and certainly before we become a formal statutory body in April next year. So whilst recognising that and the comments that you've made and the papers that have been received, I'm going to open that up for comments, questions. So I've got Kevin first. Kevin, you first. Thank you.
Thanks, Chair. Thanks, Andrew, for that. My question is the other terms of reference interim terms of reference till the end of March next year, or are they proposed terms of reference going forward from then on as well? And the reason I say that is because a number of positions there talk about CCGs, and of course April onwards there won't be numbers of CCGs. So I just wondered if it was interim till then or longer term.
Okay.
Yes, straight answer on that one is these apply to the end of March, Kevin, and again, you would expect as we develop the governance arrangements for the new statutory body that we will be reviewing those for the future at that point. Thank you.
Thanks, Andrew. Thanks, Roy.
Okay, thank you. Thanks, Kevin. Thank you for that clarification, Andrew. Nobody else indicated presently, nothing in the chat. So as I indicated earlier, colleagues, this is for approval this afternoon. So we're at item 6, terms of reference. Are we happy to approve those? Yes. Okay. Yes. Thank you. Okay. Thanks once again. Thanks, Andrew. Thank you for that.
Thank you.
Okay. We shall move on again. And we are on to item 7, I think. Bear with me. On to item 7, CCG close down. I have Dennis's name against that. That's for noting for us this afternoon. So, Dennis, are you going to lead on this one? Okay, yeah. Thank you. Thank you.
Thank you, Roy. I'm assuming colleagues have had the opportunity to have a look through the document. I know a number of colleagues have already worked with me on this and heard me talk about this a number of times, but this committee, it's the first time it's been here, I believe. So just give a bit of background to this, and then I'll summarise the document, if that's okay, Chair. So we're at the stage now where, just picking up where Andrew just left off with his introduction around some of the changes that are taking place. We know that clinical commissioning groups will conclude their tenure at the end of March. They are statutory health organisations, and therefore there's a process to do that. It's not a case of just saying, well, thanks very much, you've done your job, you can sail off into the sunset now and somebody else will take over. It's a little bit more complicated than that. So there's a transition and a form of due diligence required to transfer its undertaking, CCG's undertakings, into a new statutory body, which is the ICS. So on the 19th of August, NHS England published a number of new documents for us to consider. In amongst that batch of documents was the close down procedure for CCGs, and included in that as well was the due diligence checklist, which is Appendix 5 in your pack. It's the big spreadsheet. So what we've been doing in anticipation of that being released, we set up an executive group, which I'm the senior responsible officer for. So I lead that on behalf of the system, our system. Within that, I've got Helen Curtis, who works with me to be the programme director. There's an infrastructure that's been created, which is described in your package of information this afternoon. So we've got an executive group that oversees the due diligence process. We've recently also identified Carl Ashworth as the receiver on behalf of the ICS. So for those who are not familiar with that terminology, the senders are the CCGs. So effectively what we do, we correlate all our functions that need to transfer into the ICS. We do a range of due diligence exercises on those, and then when they're ready to be sent, we send them to a receiver, i.e. Carl, who operates in that capacity for the ICS, who then equally does the due diligence to accept them so they can embed them into the ICS new system moving forward. The checklist in your Appendix 5 just goes through all the types of different things we've got to consider and make sure that we do appropriately so we can transfer our undertakings properly and according to the frameworks. So that's the sort of background. In the package of information, just quickly go through some things that we've been doing well ahead of this. So we'd set up, as I said, an executive group that I lead. And within that, there's an architecture that deals with lots of the technical requirements underneath that. So there's a finance group, a governance group, and other technical groups that go through each of the areas that's included in the due diligence framework. So we've also got Mercer Internal Audit, who are working with us to provide support, and they've already helped us develop a critical path. When we've done the initial assessment of where we are, we fall into category 2 of the that relates to the national document that comes out. Category 2 is for areas that have got a common boundary of an ICS, so we know what the boundary is, and there's a number of CCGs that fall in within that boundary. So that's the category we're neatly placed in that. As I said, I'm not going to go through all the detail in the report. You can look at that for yourselves, and I'm no doubt you've read it and got some questions for us. I'm just going to pick up a couple of things that we need to possibly highlight in that. One of them is, like all good due diligence processes, there needs to be a risk register. So we need to understand what particular risks that we've got in conducting this exercise. Some of the issues that have come out of there is, maintaining quality and safety during lockdown, or close down, should I say, not lockdown. Lockdown's on everybody's mind, so it's closed down. Have we got sufficient workforce during close down to exercise our functions correctly? on any, is there any undue risks that we need to be concerning ourselves with that. We've also got the anticipated most difficult winter period in any of our careers at the same time as doing this exercise, and we've got the restoration of services at the same time. So it's a perfect storm of complications to manage, and hence the reason why we've set this programme up to be, I guess, ultra efficient, maybe taking a little bit more of a risk-based approach to this than we would normally do because of those factors. We've got a number of other things to think about, so how we transfer the functions appropriately into the new statutory body, which is the RCS. The commissioning functions of CCGs will transfer. We won't be able to do a massive amount of transformation on those functions whilst they're transferring, but where we can do, we will be doing it, and a number of colleagues are leading those areas. In relation to finance, Kirsty Hollis is the finance lead from our finance peers who's working with us and is leading that group. And it won't greatly surprise you to know there's lots of financial due diligence required, because the financial close down of statutory bodies, CCGs in this case, won't conclude on the 1st of April when the RCS is inaugurated. It will continue probably into the first quarter because of the obvious reasons to do that through any fiscal periods. A number of guidance documents have been published. I referenced that earlier on, which is included in your pack. There's some links there for you to have a look at as well. I would encourage anybody to start to look at that. We've got a programme, we've always had a programme plan for this, but we are recalibrating it now with support from Mersey Internal Audit. Now the Due Diligence Framework has actually been published. We've had a quick look at it, well, quite a detailed look at it actually, and we think we're pretty well geared up for that because we took the opportunity to set this up through with support of RCS colleagues a while ago, so we're pretty well prepared for that now. Some of the next steps, the governance leads and the exec groups will continue to monitor progress. We will start to also tailor some of the reports in a little bit of a different way as we move forward, because we've been developing these up until now. So we'll start to see a much more defined critical path with risk assessments on a monthly basis from here on in. So that's all I intend to say, Chair, and I'll invite any comments or questions if that's okay.
Okay, thanks. Thanks, Dennis. That's very clear. Perhaps suffice to say there's a significant amount of work going on that you've alluded to, and the groups again that you've described there are feed into the transition board, which in turn feeds into this strategic commissioning committee, and there is a report from the transition board later on in the agenda this afternoon as per normal. You're suggesting, Dennis, that there will be in future more reports to come through in a more formalised manner, perhaps, but there's a significant amount of work continuing and will continue to go ahead through the forthcoming months, and we recognise that the timescale is very tight, but as I say, everybody's working extremely hard, and we thank you and the people who are working on your behalf as an SRO for the work that you've done, the continuing work that you're going to do. So I shall move us on there to questions, comments again, and we've got Paul first and then Jeff. Paul.
Yeah, thanks, Roy. Yeah, Dennis, just a question about I think there's loads of progress being made on this, so thank you. It was a question about how we're linking in with the other areas, maybe Merseyside and Manchester. I know we've got the national guidance, and I know that Merseyside Internal Audit have got a wide geography, but I'm just wondering, are you making contact with the other teams in the different ICSs in the Northwest?
Yeah, thanks, Paul. I did start to do that when this first started a number of months or months ago. So I've had contact from similar colleagues from Cheshire and Merseyside area who are leading this. So we've been sharing our process with them and then with us. Not so much for Greater Manchester, because I'm not so sure who's leading it over there, even though I've asked some questions. But we're through Jane Cass. We've got the opportunity now to sort of harmonise that across the patch. I think there's been a bit of a delay because the due diligence framework's only just been published. So I think I know I've seen somewhere that there's I don't know the correct term, an opportunity to get us all together into one formal regional programme with programme leads in there. I have seen something that's come out on email to invite us all to a session. So yeah, sorry, long-winded answer to your question, Paul. There's a little bit of make do amend up till now, but I think it's going to go into a much more formalised arrangement. But I'll pick that up with Jane and Andrew as well.
Thanks, Dennis.
Okay, I'm going to bring Jane in next because I assume that it's the same subject. So I'll bring you in, Jane, just before you, Jeff, if that's okay.
It is.
Jane.
Thank you, Chair. Yes, just to respond to that. So the regional team did make a suggestion that we bring the 3 systems together, but unfortunately that wasn't supported by all 3 systems. So we have commissioned MIAA to work with the 3 systems directly. However, should the position change and the 3 systems want to come together, we're more than happy to facilitate that.
Okay, thank you. Thanks for that, Jane. That's helpful. Okay, Jeff.
Thanks, Roy. My question for Dennis, and I think we should all be grateful, Dennis, for you and the team doing all this, because it must be backbreaking when we're trying to cope with everything else. And I can't imagine even starting it, so well done. I've asked this question before at close down of other organisations, and the answer is never very satisfactory. So I don't expect you to excel on this one, Dennis, but I just want to be clear on the answer. And that is, where are all the documents? So we have a repository of documents, I presume, but do we have that all organised in one place, all coded, indexed and accessible to future generations? Because often, as we move into new organisations, we seem to depend on organisational memory and people's personal computers to drag old documents out. So is it any better organised now than it was at the last transition?
Short answer is, Jeff, yes.
Okay.
And the reason I say that is because we picked it up very early, because in these matters, experience counts for a lot. And those of us who've been through organisational change, one of the most difficult things we face, and probably the most irritating things, is when you move into a new era and there's something that we need to do that's going to benefit people who we serve, and say, right, okay, how are we going to deal with stroke reform, for example? And so, well, I'm sure we were working on that a year ago. Let's dredge out the documents and say, well, we can't find them. We don't know where they are. Or how do we deal with this? You lose your intellectual capital. So that's not a brilliant position to be in, and it's actually very avoidable. So I'll try and summarise my answer. The answer is it's going to be better organised than the last time we went through this. And the reason being is that part of this process moving forward is there's a very specific subsection within it where all the sort of file documents and all that sort of technical arrangements to take all your information into the new world and keep it safe and intact is all got to be filed, categorised, structured in a way in which it's logical for the receiver. So there's a very specific subgroup leading on that, which I'm glad to say are more technically adept at that sort of thing than I am. But yeah, so we're on with that, Jeff.
Thank you.
Okay, thank you for that, Dennis. Graham.
Yeah, hi, Dennis. You may not be able to answer this at this point, but in terms of the final close down of accounts, normally, as you know, CCGs accept the final close down in the May or June following the year end. Clearly, the CCGs won't be there then. So I'm imagining that all those responsibilities will be subsumed into the ICS somewhere. And just in terms of planning, I'm assuming that the CCGs will not have to approve their accounts after they've actually been abolished. So just a reassurance that the ICS will be picking up the final acceptance of the closed accounts. Thanks.
Yeah, thanks, Graham. I think this is one of the most complicated parts of this close down, but this is one where we've got some experience and learning from previous iterations. So I know we've got Paul here, and I'm sure there are other accounting colleagues on the call on the meeting who will be able to tell me if I'm wrong on this. But I think I'm not sure what the technical terminology is, but it's a form of sort of simultaneous systems. So whilst the CCGs will technically cease to exist on the 1st of April or the 31st of March, the financial close down will continue past that date until such time as the final close down of accounts is audited and all this sort of due diligence is done. So I think the process will be that the ICS will formally take over statutory responsibility for the accounts when they're inaugurated. However, that sort of the transition period between one set of accounts concluding and another one accepting, there will still be a requirement for the accountability of CCGs to make sure that is done correctly and appropriately. Am I right in saying that, Paul?
Yeah, that's right, Dennis. And I think the other thing we need to consider is which roles need to stay on, Graham, for, during that period of time to make sure there's continuity between the two organisations. So that's something that's being considered. We're not quite sure yet, or external audits aren't quite sure yet how it's going to work. So we're working with them once we understand the detail. But yeah, basically Dennis is correct.
Okay. We've also got Gary, I think, who's indicated as well. I don't know if you want to come in, Gary.
Yeah, the new finance director for the ICS professionally will have the responsibility for signing off those accounts. So part of the due diligence process, and I think that would probably involve asking whether or not the chairs of the finance committees or the audit committees can continue into the new year to provide some continuity from the CCGs into the ICS is often the way we've done it in the past. So that's one of the mechanisms that can be used. But the due diligence process is all about making sure that the evidence base, the big policy issues, any issues that are coming out of the accounts are visible for all to see, and therefore the new ICS finance director is in a position to say, I am convinced that the way in which these accounts have been closed down and the policies adopted and the consistency and everything is in line with what I would have expected, and I've been working with the audit chairs to ensure that it's possible to sign them off. Obviously the signature comes from the chief officer, so the finance director will have to advise the chief officer that they're able to do that now on behalf of, as the successor body to those previous CCGs.
Gary, could I just ask you a question on that, just about external auditors? Have we appointed will we be appointing external auditors? Or have we appointed?
Yeah, we will have to. I mean, in the old days they sort of tend to get appointed for us. But yeah, that will have to happen. But the closure of the accounts will be down to the auditors of the CCGs. They were the ones that will give the opinions. But ultimately, an organisation has to adopt those accounts. And I think the interest of the ICS is in making sure that all the transferred balances, there's proper evidence for them, and Dennis has been talking about due diligence. All the due diligence has been done to ensure that the acceptance of those accounts can happen on the right basis. So it will still have to be liaison with all those auditors. I mean, we did it when we closed down the PCTs, didn't we? We had to go through a sort of similar process.
Yeah. Okay. Thank you, Gary. Okay. Thank you, colleagues, for those comments. Dennis, I don't think we've anyone else has indicated, so appreciate your very comprehensive update there. And again, just to concur with the comments from other colleagues about the thanks to you and your team for the work that you're doing on behalf of the Strategic Commissioning Committee and the ICS per se. Okay, so that is for us to note, I think. So it's for noting. So again, we're going to move on then, colleagues. Thank you once again. We're on to item 8, which is quality and performance, and Catherine and Roger, I think with us, do we?
Brilliant. Thank you, Chair. I'll start the report and then hand over to Catherine. It's a very comprehensive paper, so I'll take it as read. There's 2 focus areas contained within the paper, and they cover urgent care and cancer. So section 3, urgent care, the section gives an overview of urgent and emergency care services, the key metrics and the challenges in the system. And this is especially important as what we move into what is likely to be a very challenging winter. So for urgent care, there's some new metrics for quality and outcomes and new standards being introduced, and those are detailed within the paper. But with regards to performance, July figures show for Lancashire and South Cumbria just under 80% achievement against the 4-hour target for A&E. And whilst failing the target, it is better than Greater Manchester and Cheshire and Mersey in that month. However, we are slightly behind Cheshire and Mersey cumulatively. A&E attendances do remain high, albeit reducing slightly in July. However, clinical audits are indicating acuity higher than pre-COVID. System pressures are often reflected in ambulance handover times, and there's been a steady increase in the over 60-minute delays since May. Relatively speaking, the July performance is around the North West average, and improvement plans have been developed and pilots have started. Bed occupancy across the Lancashire and South Cumbria remains very high and above the 85% target that supports good flow within the system. And a significant amount of work is ongoing to reduce patients being stranded in acute beds. Urgent care recovery plans are in place with improvement trajectories and a focus on system working together. That includes primary care admission avoidance, front door navigation, community pharmacies, and length of stay improvement. Moving on to cancer, while weights have not consistently been achieved for the last 3 years, COVID has made things worse, a greater challenge, and targeted work is needed to address inequalities and access for those slow to come forward. The Elective Care Recovery Group monitors performance against cancer metrics, and our Cancer Alliance performs really well against other alliances in restoring referral rates against the 2-week target, but poorly for the 62-day treatment target. There is an improvement plan for cancer weights, and that includes increased diagnostic capacity to clear the backlog, working with NHSEI improvement support team, investments in tracking, working with primary care, and NHSEI also have an improvement plan for screening programmes. The Cancer Alliance also has a transformation work plan. The restoration for Cancer Alliance is 115% for referrals, but only 89% for treatment, so you can see how a backlog might be created. Moving on to diagnostics, the numbers on the waiting lists continue to fall in June, but differential across providers. However, the percentage waiting over the 6-week target has increased. Endoscopy capacity does remain an issue, and recovery plans are being developed and monitored through the ECRG. Moving on to elective care, GP appointments are back to pre-COVID levels, albeit the type of appointment seen has increased in the non-face-to-face category. Subsequently, referrals into hospitals have increased. However, activity is not kept pace with pre-COVID numbers, which can result in a waiting list growth. The rolling 4-week recovery at the start of August was strong. It was the strongest in the North West, albeit the last week was reduced for elective admissions, but for outpatients we are a little bit behind compared to the rest of the North West. Actual active recovery against targets in July do look challenged, and this will affect potential resources that were expected to come into the system. Restoration plans continue to be progressed, and that will cover elective admissions, outpatients, diagnostics, the independent sector and critical care. The size of the waiting list in June moved up to 155,000, and against the 18-week standard target, it was just under 71%. We have nearly 10,000 people waiting over 52 weeks at the end of June, of which 233 have been waiting over 104 weeks. There's been a slow decrease in the over 52 weeks in June. However, the 36 to 52 week waiters continues to grow. And that's for the 4th consecutive month. Referrals for 52 week waiters would have been suppressed 52 weeks ago. But all trusts do continue to undertake the National Clinical Prioritisation Programme, and that's treating patients in the clinical priority order. I'll just hand over to Catherine, who'll pick up the rest of the report.
Thank you, Roger. So I'll start in section 7 around nosocomial infection. So LTH, you'll remember last time, were the trust within Lancashire and South Cumbria who were reporting the most significant issue. I'm pleased to report that there's been no nosocomial outbreaks during the months of July and August, and that is being monitored. So those outbreaks, what has happened is they've introduced daily lateral flow testing for staff and are picking up those that are asymptomatic. Lessons are being learned across the system, and that is being closely monitored, obviously, as we see the returns to school and returns of workforce coming back in. So that was good news. Just to escalate really within workforce, and to say that as of the 11th of November, if staff are working in care homes and they haven't been vaccinated, then they cannot continue to deliver that care. So they need to be vaccinated by the 16th of September to enable them to have had both vaccinations by that date, the 11th of November. And we have a list of homes that are across Lancashire and South Cumbria with the highest percentage of staff with staff that aren't vaccinated. So we're targeting those homes all across, and are trying to encourage and have clinical conversations with those staff who are showing some hesitancy around the vaccination. That is on CCG risk registers and has been escalated as well into the cell for vaccination, because that will be a key marker for us, particularly as we step into winter around the workforce. We are monitoring regulated care as well in relation to the number of outbreaks across the ICS, and we can see those now starting to increase. What we are seeing is that most of those residents have been doubly vaccinated and are not requiring hospital admission, but are requiring some support from community services or general practice. So the pressure is still around that sector. In relation to phase 3, planning for COVID vaccination, that is continuing, but just to flag to committee that there will be some delay in the delivery of that scheme against the first national guidance, which was to start on the 6th of September. We will now start around the 20th of September. We're waiting for national guidance to come in. We have had a very good response from all PCNs across the ICS who want to take this on and do the booster programme. We're also working closely across the ICS to target the 16 and 17-year-olds, those that are about to start college. And we have mobile vaccine units that are working all through and during this weekend to target that group as they step into colleges. We are waiting for guidance to come through today regarding the school programme to commence vaccination with the 12 to 15-year-olds. So the expectation is that vaccination will start in schools as of next Tuesday, the 14th of September. So all planning is in place for that, and we're working very closely with the school provider and working to try and do separate programmes for COVID and for flu, and not do the dual delivery of that, because the programme for flu is set and we don't want to unstable that programme. So that will be happening. There's training going on for staff and to support the workforce, because some of that workforce have been focused on adults. There will just be some update training to ensure that that can be delivered safely and at pace across that school sector. Programmes will be being worked up to share with parents and teachers so that people can consent and they're fully aware of what that consent is and what it means to have that vaccine. Just section 8, the individual patient activity. The project to address the legacy of incomplete referrals is nearly complete. There are 4 patients now across Lancashire and South Cumbria, and there are regular meetings in place that are weekly around that cohort. Families are being worked with so that they're fully aware of the situation and involved in that planning process. In relation to safeguarding, we are running a pilot at this point in time to work with our designated professionals and our CSU team in relation to the Court of Protection and the legislation around the applications for courts of protection. I will bring the update back into committee when that has finished around the Christmas period. So it will be New Year around how that will continue to be delivered going forward. For CAM services, you can see the position all across the ICS, and this is a very challenged position in relation to the demand for children's and young people's services and for mental health. You will see in the report under 10.1.2 that it states there's no harms being reported. We are looking at that and just to consider what we mean by that. How is that being measured? What's the definition of that? And how do we examine that harm? We're working with young people who are on waiting lists and are going through those pathways to help us inform that. And again, we will bring that back to committee around those key outcomes. Families are being supported and staff are being supported both in relation to capacity and managing those pressures. So it's vital that we understand that experience and where we can improve those pathways. In relation to eating disorders, you can see from the report, and I won't go through the figures, the demand for this service. This was expected when we saw some of the issues that were coming from lockdown, particularly around young people. And the demand for these referrals has increased across the country. They have increased across Lancashire and South Cumbria, but this is a national problem. The number of complaints received for this service has increased, and we are working with some of those young people to help us to understand again what their issues have been and what those family issues have been. We're also working with the providers to look at the capacity of these services and how we can support that service to deal with this demand. There are a number of people on waiting lists, and those waiting lists are being risk assessed by clinicians on a regular basis, and they are being fast tracked through that service. Again, this area has been added to risk registers because the capacity to deliver at the moment isn't as robust as that demand. So that is an area that we are looking at very closely. In relation to adult mental health, we are looking at that performance, and again, we are putting in a perfect week around the urgent care pathways for mental health. So that will happen at the beginning of October. And again, now we'll bring back those outcomes, looking at that experience, the effectiveness, the pathways, and the feedback on that. The mental health detentions, you can see, I do apologise, there is a typo in the paragraph 1 that should read Q4, just to Q1, apologies, instead of Q4. So just to flag that into committee. The out of area placements, again, you can see from those figures that that has been an issue. It has decreased slightly over this last month, but work is very much going on to look at those placements and the safety of those placements. Again, looking at admissions and discharges and flow. There's a weekly meeting in now to consider all of these patients and to look at how that is managed going forward through the autumn into the winter. sector, and again how we work multi-agency, which I think you'll all agree across Lancashire and South Cumbria is good to enable us to do that. Suicide prevention, unfortunately we do continue to have these incidents of people completing suicide. We are looking at that in relation to any clusters. There's a specialist team within the mental health services looking at those hotspots and providing care both into families and across that services to how they can be best supported. But it's very much around how is that prevention happening? Where do we need to target? How do we target? What does that comms need to look like? And how do we get those people before people dip into that crisis position? In relation to MAS and older adults, just to say that there is a capacity and demand deep dive that has commenced at the beginning of August, and we will bring that back in, looking at those improvements into next committee. And finally, just in relation to learning disabilities and autism, just in relation to Q1, there's been 22 CCG admissions and no secure admissions, with some readmissions on that. So again, we will be looking and engaging and continuing to work with that cohort. Those are the only points that I would like to flag in. Thank you, Chair.
Just on mute, Chair.
Roy, I think you're still on mute, I'm afraid.
I am. I'm sorry. I was just saying thank you to both of you for that report. Apologies for that. I've done that twice this morning. Yeah, comprehensive report, and it's entirely appropriate it's brought before the Strategic Commission Committee. Just one point I would make, having read the report, it seems to focus significantly on performance and less on qualitative aspects, I think, of the services that are being provided. And I was just wondering about the balance of that, Catherine. So I can see you nodding there. Perhaps I could bring you back on that point, if that's okay.
Yes, no, thank you, Chair. That has been noted, and we are working as a group to readdress that and looking particularly around those quality aspects. And you will see that shift going forward, that there will be more of a focus on those quality elements. Okay,
thank you. Okay, thank you for that, Catherine. Okay, thank you, Andrew. Did you want to add anything to what Roger and Catherine has said? You know, you're not first on the list, but I'll just bring you in first.
Yeah, thank you, Roy. Just a couple of things at this stage. I think Roger and Catherine have a real challenge here, because we are looking at so many indicators and issues, and any one of them actually merits quite a discussion. I think one of the obvious challenges here is that we've got services that have a really busy workload and are trying to catch up. And actually, there's a lot of good news in there, and there's also a lot of challenge that's going to take time to recover from. So there's a way of responding and listening to some of this, I think. And one of the things I think we need to do with you is just look at some of these patterns over a time series, so that we can see whether a service like CAMHS, which is going to stay under pressure for a while, is still making progress, or whether there's additional areas that needs some support. And I wonder whether the committee, particularly knowing we have a quality and performance subcommittee looking at some of this in more detail, whether we could get into some of that progress over time conversation. The only other thing to say, Catherine, you made a mention of dates around child vaccination, the 12 to 15 year age group. Now, I was in a meeting yesterday where I was left with the impression there was still some further national discussion required around timelines for that vaccination programme. So I just perhaps want to put a qualification there that I think we might still be waiting for a little bit of further national guidance on that. And that perhaps just important to bring that out at this stage in the discussion. But I might come in again, Roy, but I'll let others that queued up ahead of me. Thanks.
Okay, thank you, Andrew, for Of a number of people indicated, so what I will do, I'll take them in tranches of 3, if that's okay. So I've got Peter Gregory, then Paul King and Graham Burgess first. So it's Peter, then Paul, then Graham. Thank you.
Thanks, Chair. It's interesting that you should mention there about the having the right balance between quantitative and qualitative data, and I think that is something that has been commented on before, and I welcome that, because I think we need to find the right blend to really understand performance, particularly in an integrated care system. But my hand went up in response to a comment by Roger, and I don't know whether it was Freudian or it was deliberate or evidence-based. But the interesting thing you said was commenting on the change in the proportion of appointments in primary care from remote to face-to-face, and you said subsequently hospital admissions have gone up. And this is an important issue, I think, because we're seeing quite a lot of this in the media at the moment. And my personal feeling about this is I don't know if we know, and this is why I'm asking the question, to get underneath that comment a little bit. Do we know that there's an association there? Do we know what patients are actually happy with? And do we have a direct correlation between the proportion of what type of consultations occur in primary care and how that's impacting on secondary care? And this is, of course, is important because we're still trying to understand what the right model of primary care should look like moving forward. You know, we know we want to increase the number of proactive episodes of care through population health management, and that our capacity may be enabled by remote consulting, but we're also perhaps dampened by expectations to maintain a certain traditional model. So we're still trying to understand, as a primary care system, what a model of primary care looks like. So it's really important that we understand the correlations between what we're doing and how it impacts on secondary care. Thanks,
Okay,
Chair.
Thanks, Peter. I'll just leave Roger to think about that for a few moments while I bring a couple of other people in. I've got Paul then first, and then Graham. Paul.
Thanks, Roy. Yeah, I mean, I recognise Andrew's comment that Roger and Catherine can't possibly know all the answers to all these numbers and activity details, because it's a massive report. So that's just a noting, really. But I did agree with colleagues that I'd represent Fylde today in the meeting, as well as West Lancs. So I've noted on the 52-week wait, there is a bit of variation, and Fylde Coast does seem to come out a little bit worse on the waiting list. So it was whether we understand, I know you allude to it in the report, but whether we understand any of the underlying reasons, and whether there's any actions in particular that are being done, and whether there's any mutual aid that we can do to try and reduce that variation for patients. Okay. Also, I do know as well, I know the latest funding announcement, particularly tackles waiting lists as well. So hopefully the detail will, when we start to see the detail of the funding, there might be some funding that we can apply to this as well. You're on mute then, Roy, I think.
I am again. Graham, sorry, I'll bring you in next.
Just in terms of out of area placements, is there a geographical breakdown of where these people are living before they're placed out of area? In other words, is it more in Pennine or Central or Blackpool, or so? Do we know where these people reside, and is there a particular problem in any part of the Lancashire and South Cumbria area?
Okay, thank you. Thanks, three of you. I'll come back to other colleagues who've indicated in a few moments. So we've got 3 issues, I think, there. Peter raised to primary care. Paul was about variation, and I think was about the residential or the geographical aspects of it, of the position. So Roger, I'll come back to you first, if that's okay. I think Roger might have frozen. I'm not quite sure. Doesn't look like there's much movement there. Catherine, I don't know if you can pick any of those up.
Can I pick up the out of area placement one? I can certainly provide that information. We do have that where that person would have resided and then where they're placed out of.
I think, can you hear me, Chair?
No, you're sort of in and out, Roger. I've just got Catherine on at the moment. Can you just hang on one moment? Catherine, carry on.
I can provide that information, and obviously some of the patches are a lot larger than others, so we need to do that per weighting. But I can certainly bring that through to committee and get that information if that's helpful.
Okay, thank you. Thank you for that. Thank you, Graham. Okay, Roger, I think, are you back with us? Yeah.
I'm not sure. Am I, Chair? Can you hear me?
Yeah, you're back. Yeah. Okay. Thank you.
Apologies for my Wi-Fi, and I think there was a delay in the system, so if I talked over Catherine, I do apologise. Just in terms of Peter's question, and thank you very much for the question, I tried to link the increase of appointments to the increase of referrals, not in terms of how those appointments were actually delivered. So that was my point on that. So apologies if I confused the two. With regards to the Foul Coast, Paul, I think there is something a little bit different that we need to just take offline and understand a little bit more, as this, with the Spire Hospital being located there and delivering services, that does put a different dimension in terms of the waiting list and numbers that are associated on the Foul Coast. So we do need to follow that up, and I'm sure colleagues at Foul Coast CCGs will be well aware of the reasons why that's happened. And yeah, and Graham, we are able to split OPEs by placements, but I suppose also to recognise that an OPE is when you're not in one of the LSCFT's beds, for instance. So you could have an OPE that is local, as well as a note that is further afield. So just to note that as well. So thank you, Chair.
Okay, thank you very much. I think that's answers acceptable to everyone. So thank you. Paul will pick that up perhaps outside the meeting about the variation that you talked about, Roger. Okay, I'm going to take three more people. I've got Samantha, Kevin, and then Jeff. Can we take in that order, please? Samantha first.
Thank you, Chair. Thanks, Roger and Catherine. I'm just wondering where we stand in terms of risk in this situation, in terms of vaccination. There will be a small subset, but a significant, I suppose, who would be coming back into the country. They could be UK citizens, or they could be citizens of other countries who might have been vaccinated abroad with a vaccine that we do not approve, or the UK government that does not approve. So where do they actually stand then in terms of work and other things? I suppose with the shortage in the workforce, that will become increasingly important. And also we are going to have refugee settlements as well. So we need to have some sort of policy, or do we have any directions from the national government?
Okay, thanks for that, Samantha. Perhaps I'll take up other people with questions first, but perhaps I'll come back to Andy on that one. Okay, I've got Kevin and then Jeff.
Yeah, thank you, Chair. And can I start by saying thank you to Roger and Catherine for the report, because I think it is a very difficult task you've got there, trying to report on so many things and involve just the right amount of data and all that sort of thing going on. My observation, or a question actually, first of all, is this report going to develop into an all-provider report for this committee? It seems very much secondary care based at the moment. And a couple of examples as we were going through, the point Peter made about the correlation between primary care performance and its direct impact on secondary performance is probably sort of quite a common theme. So first question, is it going to be broader than secondary care? Will you be reporting on all providers within this document? And will it sort of dovetail together so that that impact from one to the other can be seen easily?
Okay, thanks, Kevin, for that. Just what the last speaker within this 3 is David Blacklock. So David, yourself. Or have I got you, Jeff? Sorry, have I missed you out there, Jeff? I think I have. Sorry, Jeff. Jeff, I'll bring you in. I'll bring you in first. You're on mute, Jeff.
I realised that. I was just swearing about you, so I kept.
I bet you were, yeah.
No, I was just saying, how could you do that to me? This isn't this is more of a statement and an observation rather than something that requires an answer, and it's certainly not an attack on the report or the authors. I think the report's really good and helpful, although it's very big, obviously. But I think it has to be said because this is a meeting in public, and this is a very hot issue, and the commentary about primary care activity needs a bit of explanation. The first thing I'd say is, you know, the report's numbers don't give true justice to the actual activity in primary care, and it must be something about a coding issue, the way we record our activity and the like. But very reputable studies of primary care out with the NHS in journals and the like are showing that general practice activity is generally 30 or 40% up on a comparable time 2 years ago. Then remember that everything we do is taking a lot longer. And I would say these comments refer to other services as well. I'm not saying general practice is the sole victim of what's happening at the moment. We're all under the cosh, but I colour it with general practice because that's where I come from. So everything takes a lot longer. So typically in my life, and other GPs may say something different, things are taking 2 to 3 times as long. Firstly, there's a lot more complexity about at the moment. People have saved up a lot of issues and are presenting with several issues at once, and the infection and prevention control measures that we have really slow us down in face-to-face. So we're doing a lot more activity, and we're taking a lot more time about it as well. So the actual work in terms of hours GPs are inputting at the moment is massive and unsustainable. You know, and I think we have to say this because this is very hot in the media at the moment, and you know, what can I say? You know, there's a criticism in the media supported by some elements of people who work within the NHS, I have to say, that actually GPs have been a bit lazy and they've got the doors shut, and this is absolutely not the truth. We are very busy, we're very active, and I accept the comment that GP activity is not coping with demand, and that's because demand is massive. Demand is massive across mental health, across primary care. The ambulance service are struggling. We know this, but it's not because these services are being lazy or slow or inefficient. It's because capacity is massively exceeding demand. And I think that needs to be said in this public meeting. And actually, I think that is the key message of the time. Thank you for listening.
Okay, thanks, Jeff. Right. I'm going to come back to the comments that were made there. I'll take Samantha's first, which is about vaccinations. Andy, can I come to you first on that one, if that's okay?
Yeah, thanks, Chair. Samantha, it's something that's come up for some individuals. It's not a blanket rule because it depends on the vaccine. It might not have been approved by European Medicines Authority or MHRA, but that doesn't mean it's not a different vaccine. So it's very much individual rather than blanket based. Some of the vaccines would be approved, but the licensing just wouldn't come through, and so they wouldn't receive. Individual case basis as well, while we discuss about third dose boosters for people. So if people had very early on, then you'd have a lower threshold for giving them a booster now, as opposed to starting a new vaccination regime. Anecdotally, I have given a new course to someone that had been vaccinated abroad, and I had no idea what they'd had. So it's an individual rather than there being any central guidance about it. The vaccination cell is still up and running, so we do have a route to escalate any queries, and I still get queries through from GP colleagues with people presenting to practices that if we don't know, we have a route to escalate right up to the centre. So I'd encourage people to spread the word. If they have questions, go through the existing covered vaccination route and they can be escalated up, because if one person's asking, I'm sure someone else will be.
Okay. Thank you. Samantha's nodding there. Okay, so we've got a second question from Kevin, was talking about an all provider report, I think. Either Roger or Catherine on that one.
I'll start. I don't know if Catherine wants to join in, but I suppose Kevin's and Jeff's points were really well made. We do cut the report in 2 different ways, by provider and by population, but in terms of where we can get data and good quality data, it will enrich the report going forward. So we do try and pick out how primary care data does fit in and tell stories to what's happening into the system. Community data is data quality issues and may be an issue with them, so we need to work and develop that as we go forward. And I suppose the graph around GP appointments in the pack does show that in June 2019 there were just over 600,000 appointments, and in June 2021 there were just short of 800,000. So you've got a significant increase being shown on that graph in terms of that activity, which is telling and does kind of like.
I think we're losing you again there, Roger, unfortunately. Just wondering if it might be a bandwidth issue. So could I ask colleagues, I perhaps should have said this in the meeting, if you're not speaking or you're back now or not indicated, I think it might be a good idea if you switch off the videos maybe at the present time, because we seem to be struggling a little bit. No, I think we've lost you there, Roger. I'm going to come back to you, Catherine, if that's all right. Catherine, are you there? Yeah. You're on mute, Catherine.
Sorry, I'm doing it now. Yes, no, as Roger said, we will be looking, and we're certainly having conversations with our general practice colleagues around what information we can get. And some of that information does come through on an annual basis, but around KPIs, around screening, what would be useful. And I think, you know, previously we have reported around community services such as dentists, optoms, etc., and given that very rounded picture. So I think it will become broader as we step into that remit.
Okay, thank you, Catherine, for that. Jeff, I think yours was more of a comment than a question, really, which was, I think, has been spoken about by Roger. So thanks for bringing. I think the majority of us on this meeting would concur with the comments you made there. To understand the work that's going on in primary care and the pressures that are existing within those particular services. Okay, Andrew, you indicated you might want to come back at this position. You don't. David Blacklock, you did indicate your hand was up, but then I think he's taking it down again. I don't know if you want to come in there.
Yes, thank you. Thanks, Ronnie. That's great. Just a couple of things, really. So just first of all, responding to Peter, Healthwatch Cumbria and Lancashire produced a report which was looking at patients' experiences of online consultations via primary care. So what I'll do is I'll circulate that, but it describes how people find using online consultations, and it's quite surprising in its findings. So I'll send that over to everybody just out of interest. That's the first point. The second really was for Roger, and it's about the one of the comments that you made early on when describing talking about cancer targets. You said that there was a delay in people coming forward, which obviously then has a knock-on effect on treatment and support that's needed. So I just wondered whether or not there is anything that's particularly going on about that, about supporting people through comms and engagement to help people to come forward earlier. What's the plan? What's the strategy? Because clearly that's obviously very important.
Okay, thank you, David. Perhaps if you could send that report to Sandra, and she could circulate it to members of the committee, if that's okay with yourself.
Absolutely.
Yeah. Absolutely, that's great. That's really helpful. Thank you, David. I think we've lost Roger at the moment. As I said, I think he had a problem with his internet connection. So, Catherine, if you picked up any on any of that, yes, please.
Yeah, thank you, Chair. David, I think that's a really fair point. There's been lots of comms out and big campaigns from our Cancer Alliance colleagues around general practice being open if you have a symptom to go, to get that checked out. So we are seeing, and some of the feedback we're getting from general practice is that people are now coming forward. They are seeing those presentations. but it's about that encouragement and getting people to talk and perhaps getting people to disclose information in a different way. We just talked about those virtual consultations, and some people may be embarrassed about that. But there's certain campaigns around, you know, bowel cancer, lung cancer, look for these signs, see your GP. So that those, if we're seeing that as a theme that is going to continue, we need to relook at that, because the message is absolutely get those symptoms checked.
Okay, thank you. Okay, Andrew.
I mean, just speaking to this issue of cancer, the report does confirm that referral levels are back above the level that they were during the pandemic. So people are back coming with their symptoms and presenting, and GPs are referring them. So I think our Cancer Alliance is seeing levels of referral that are significantly higher than some other parts of the country. So I think we can have some confidence that services are returning to a normal in that sense.
Yeah, I think just in terms of diagnostics, Andrew, and just following on from that comment you've made, there seems to be an increase in diagnostics and endoscopies and things like that. I was looking at those figures the other day. I think aerosol generator procedures are back on the agenda. I think they are. Therefore, will this result, I think, in seeing an increase possibly in patients now being able to attend those procedures? Will we possibly see an increase in those cancer figures or wait times? Andy?
I think one thing just to make clear, Chair, is the IPC guidance still remains in place. So for elective procedures, for a 2-week period of isolation with the swabs that need to be required, and there's ongoing discussion with the national team. So it's getting that balance of people being harmed because we're not able to see the same numbers of people coming through versus people and other patients who could get harmed who are in that same environment or members of staff. The national IPC guidance on isolation before elective procedures is literally being rewritten as we speak. And the Northwest region have had the chance to input to it from the regional team, not from our IPC team. So we are still bound to follow the guidance that's been in place the whole way through the pandemic. And until that changes, it will be hard to then really ramp up the numbers. But as Andrew said, we're already reporting a far higher return than other areas are. So it's all thanks to the provider teams that are getting through huge numbers of patients safely following the current IPC guidance as well.
Okay, thank you for that clarification, Andy. That's much appreciated. Okay, I have nobody else indicated presently on this item. So it just remains for me to say thanks once again to both Roger and Catherine for presenting this hugely comprehensive report that other people have referred to. So we do thank you for the amount of work you put into with regard to that. And I shall ask the committee to note the contents of that report and support its future development. Are you happy to agree that, colleagues? Yes? I can see some nodding. Yes. Okay. Thank you once again. Thanks once again to both of you. Okay, we shall move back to the agenda. And we're on to sort of part 3 of the agenda, which is building the system for 2021 and 22 and beyond. And we're on item 9, which is the new hospitals programme Q1 report. Jerry, I think that's for yourself. Thank you, Jerry.
Thank you, Chair, and good afternoon. It's nice to be able to kick off this section about 22 and beyond. I promise I won't bring too many Buzz Lightyear quotes into the following section. It's worth starting off, of course, just reminding ourselves, but the new hospital programme is very much about thinking for the future, and a real generational opportunity for all of us in Lancashire and South Cumbria to think about how our hospital services will work and be configured and fit within our wider system, looking forward to 2030 and beyond. The paper I'm going to take as read, but it's a Q1 report, so I'm going to try and embellish a few areas around this to reflect what's been happening more recently. I'd also like to stress and just remind people that the new hospitals programme in Lancashire and South Cumbria is very much part of a national programme to build 40 new hospitals. The national programme team are continuing to develop and build a strategic approach to this, and we are very much part of a national phasing for the new hospital programme. This means that we are continuing to work with the national team in partnership with them, but this continues to have a significant impact on the timing and phasing for the work moving forward. That said, there has been significant work done over the last 3 or 4 months, which I just want to highlight. The first is around our engagement. Committee members will be aware that we published the case for change back at the end of July, and that has been a major part of our engagement with the public regarding the new hospital programme, taking in all of our different avenues of communication with the public. We've had something in excess of 170,000 points of engagement with the public now, and through our Big Chat web engagement tool, over 20,000 NHS staff, trust board members, trust memberships have also now engaged in the programme. So I'd just like to reflect on just what a tremendous job the communications engagement teams across all of our organisations are doing to promote the new hospital programme. One of the things that we are starting to do as we come through COVID and out of COVID is to think very carefully but diligently about how we increase direct engagement with the public. We are partly doing that through making our website more interactive, but also increasing our attendance at meetings, including health and wellbeing boards and scrutiny committees. The second thing I wanted to just draw your attention to was the framework model of care. And again, I want to start off by recognising the amount of work that our clinicians across Lancashire and South Cumbria have contributed towards the development of the framework model of care. And I know some of the GPs on the call have been directly involved in helping to develop that model of care. That work is now being complete in its first phase, but I just want to highlight that the framework model of care, which is a reference document for the new hospital programme, is now being taken forward through the new clinical collaboration board, which is part of the provider collaborative board, to look how the new model, how the new hospital programme model of care will work with the ICS clinical strategy to help to continue to develop our hospital strategy for the future. And it's worth really emphasising that the new hospital programme really should be responding to our clinical strategy, not driving it. And it is something we're very keen to make sure we are cognisant of, even if the timing do not always quite align in the way we would like to. My final point just to raise with you is to reflect that in the last week we have published the initial long list of options for the new hospital programme. This is a standard requirement for us in line with public engagement and in line with the National Green Book for large-scale capital investments. We've published 10 options, which is widely now available on our website for people to review, and more importantly, to engage with and give their feedback about their thoughts about the different options we publish. In line with the national programme's new playbook to describe the new hospitals programme, we have highlighted that options include new buildings and new hospital buildings on new sites, rebuilding of existing sites, as well as refurbishment. These are all different options that we need to consider as a possible route forward for the new hospitals programme. We will be continuing to seek people's views on the long list over the next few weeks with an aim to start the shortlisting process during October. I'm very happy, Chair, to answer any questions that anybody has, but once again to reflect on what an enormous opportunity and a very positive thing to look forward for the future. Thank you, Chair.
Thank you, Jerry, for that very positive report, and I'm sure members of the committee this afternoon would join with me in thanking the clinicians who've inputted into this report that Jerry referred to during that presentation. Thanks again, Jerry. I've not got anyone who's indicated presently, so you've just proves what a good job you've done there. Oh, yes, I have. I've got Andrew.
Jerry, what you've just said, thank you for the report firstly. What you just said about some of the distinctions between those long listed options is really quite important for us to emphasise, isn't it, today? And I just wonder how connected that is to some of the feedback that you've had from this extensive engagement process. What are the sorts of flavours that have come through from members of the public and from clinicians about what they want from hospital services in 10, 20, 30 years time? Could you just give us a sense of that, please?
Just before you come in on that, Jerry, I've just got David, which may be the similar subject. So I'll just bring you in again as well, David, before Jerry comes back to us on that.
So my question was for Jerry, really about engaging with some of those kind of the louder voices in our communities. I'm talking particularly around potentially the campaigning groups that have got quite strong views about some of these issues, and just seeking to understand a little bit more about what engagement has taken place with them. And just to let you know that a number of those groups have come together and asked for a meeting with ourselves to kind of just have a look at this. Obviously, the new hospitals programme is of particular importance to them as groups. And obviously we need to ensure that we've got absolutely the right kinds of engagement with them. I'm sure that's something that you've given a lot of thought to.
Okay, thanks, David. I've just got one more person indicated, Jerry, and I'll come back to you if that's all right. Richard.
Yeah, thanks, Roy. I was just wondering about the level of interest in the clinical strategy. So to me, it seems key, really, when you're thinking about that list of options that you've got out there, that they could be heavily influenced by that awareness of how that clinical strategy might work going forward. It could fundamentally influence how people might form their views. So are people as interested in the clinical strategy as they are the new hospital programme? That's the question.
Okay, thanks, Richard. Thank you all for your comments. Jerry, you want to come back on those?
Yeah, thank you. So first of all, to start off with Andrew's comments, I suppose there's two aspects to this. I think firstly, I'll be careful how I say this, there has been quite a lot of work from the national team and from the government to provide greater clarity as to the context of what a new hospital programme entails and includes. I think it's fair to say that most people had jumped straight to the view that that meant a big new shiny building on a new site. And we have worked in partnership with the national team to recognise and reflect that a new hospital can mean one of several or a number of different opportunities. And in terms of return on investment, it's entirely appropriate that we take into account the potential to build on existing sites, keeping the best estates as much as we consider the potential to build on a new site. So I think this part of this has been clarifying the national message. That said, the feedback we're getting, particularly through the big chat and through other portals, I think clearly reflects the spectrum of views that people have about what's important to them. We have seen people with very strong views around a new single hospital offering much greater opportunity to bring together workforce, to improve our research and education, but equally very strong divergent views emphasising the importance of local access and the community nature of our hospitals, and that they are very much anchor institutions in our community. So I think it's fair to say incredibly thoughtful, insightful feedback, but across a very wide spectrum and often conflicting views in terms of people's views. And of course, that's the challenge for us, to get this as right as we can for as many people in the future. David, in terms of your comments, I think clearly the challenge for us, but a very important one that we get right, is we have to be seen to be listening to and hearing from everybody, both those with the loudest voice, but equally those that are seldom heard and least often heard. So we've been doing some great work with Healthwatch, with the support of Healthwatch, particularly in terms of accessing some of the more challenging groups in terms of those that are heard least often. That doesn't mean that we shouldn't equally engage with those that have a lot to say and want to be engaged. And we have certainly reached out. I have written myself to a number of groups extending the opportunity to speak. A number of our borough councils, in fact, have been quite active in saying they'd like to meet us, and we are offering to do face-to-face public meetings through our borough councils as well. So that clearly the offer is there. Our intent is to listen to as many and as broader groups as we can. It should also be fair to say that we have been engaging extensively with all the MPs as well, which again has been very positive in terms of the level of cross-party support for the level of investment into Lancashire and South Cumbria. Richard, in terms of your comment, you know, I have to be careful about differentiating the ICS clinical strategy from the framework model of care. The framework model of care really brings together our clinical views around what best practice needs to look like in 2030 and beyond. I'm really impressed by the amount of time the group have spent thinking about how digital technologies and new technologies will influence the way we work, and they've tried to reflect that very strongly within the framework model of care. I can't underestimate the importance now of the framework model of care being brought together with the ICS clinical strategy, making sure the work we've done thinking about hospital services is as balanced and as innovative as our thinking about the future of general practice, community services, integrated community services, because the future of the hospital programme is going to be only successful if we really get our vision and our future around the community services in the wider sense of right as well. So I'm hoping the framework model of care, it's not a finished document, it's a document that I think will inspire more conversation, and that's the thing I'm really hoping to see through both the provider collaborative board and through our community groups, that we really start to see that work take forward.
Okay, great, thank you, Jerry. Andy.
Thanks, Chair. It's just backing up what Jerry's saying, and it's a reminder that the hospitals programme is one way that we will successfully implement the clinical strategy. There's very, very many different parts of it, and you're quite right to suggest that people might not be excited about the clinical strategy at the moment. The document that was approved is literally just a document, and with the support of Neil's comms team, we've just produced a video where we're going to try and go out and launch it and start to get frontline staff and also the public more interested and excited about the clinical strategy. Timing, as you know, is everything. So it's having something to really illustrate it with, and the new hospitals programme is a perfect way of illustrating what a good, strong clinical strategy is. But with that goes the clinical leadership. So again, we're bringing in that leadership programme that's coming through, and Jackie Hansen leading a piece of work across our system for that. But it's all the clinical leads on this call as well to speak to the clinical strategy and to make an exciting live aspect for them too. So future support would be much appreciated with that, as I'm sure it will get. Thanks, Chair.
Okay, thank you. Thanks very much, Andy. Okay, Jerry, thanks again for providing us with that report and quarter one. The recommendations today are for us to note the progress currently undertaken in quarter one and the development of the products to support the business case development in section 5 of that report. So are we happy to agree that, colleagues? Yes? Yes? Okay, thanks once again. Thanks again, Jerry, for coming along and reporting that to us, and we look forward to seeing future reports from yourself on this new programme. Thank you. Okay, move back to the agenda. So I'm on to item 10, which is from Lancashire and South Cumbria Medicines Management Group, commissioning policy positions. There's 2 items on here. There's policy development implementation group. Just before we move into that item, I want to apologise for the reports on this particular item. They were late coming out, and there was some issues there about how they were circulated. So apologies for that. So I'll bring you in, Brent. Thank you. Items 10A and B.
Yeah, thank you, Chair. Today, as the Chair's pointed out, I'm here to talk to 2 outputs from 2 committees and to apprise the committee of the outputs of those and seek ratification. So the first, which is on page 124 of your pack, is the outputs of the Lancashire and South Cumbria Medicines Management Group. So this is the actions from the July meeting of that group, and there are 3 local policy positions that were agreed, which are set out in the paper, and there's also 2 NICE technology appraisals. The specifics relate to hydrocortisone granules. That's anticipated to have a low impact on the health economy. Sodium oxybate for narcolepsy with cataplexy, which you'll note in the paper, based on NICE estimates, have a relatively significant impact. However, we're aware from the number of IFRs that we've received over a number of years that we expect the number of patients to be significantly lower than set out in the NICE population estimates. And then the third relates to Sativex, which is for spasticity relating to multiple sclerosis. This is a change in position. So previously the position was specialist only, and that's now to move that into initiation by a specialist, but moving into primary care if the patient's stable. The NICE technology appraisals again are expected to have a small impact, essentially for 2 reasons. The first is that there was a small number of patients, and the second is that there's a new drug that's been recommended that has a similar price to medicines that will be used at the same part of the treatment pathway. So really just wanting to seek from the committee whether you have any queries, and if you're happy to ratify those policy positions as written.
Okay, thank you for that. A note to Jeff there in the chat. But yeah, I won't attempt to say what those are, Brent, but you've explained those very well. So thank you for that. So I think we're asked to ratify that, colleagues, unless anybody's got any questions they would like to ask Brent on this particular item.
Yeah,
so
I agree, right?
I'll just ask to ratify, yeah. Okay, thank you. That's the ratifying the recommendations from the Lancashire South Cumbria Medicines Management Group. Okay, so we'll move on to 10B. Brent,
perfect. Thank you, Chair.
And yes, all together. Do you want to take these separately? There's 3 here, isn't there? Take them all together.
There's 3, but I'll take them all together because
okay.
2 are minor updates. And yes, apologies, Jeff. The technical nature of some of the medicines management ones are quite challenging at times. So the outputs from the Commissioning Policy Development and Implementation Group, there are 3 updates to policy positions that are set out in the paper, and that starts on page 130 of the pack. So the first relates to an update to the dilatation and curettage policy. Essentially, there is a minor amendment into that policy, so no significant changes in terms of clinical. There's been an evidence review, and which has indicated that there aren't any significant changes. As is usual when we've just done a minor amendment, so we've left the track changes so that committee members can be apprised of what those changes are. The second is another minor change, which relates to male circumcision. Again, an evidence review was conducted. There was one minor amendment in terms of the title of the document, but actually nothing in terms of clinical content. And again, the changes are tracked in that document. And then the third relates to carpal tunnel policy. So this has some changes. The Commissioning Policy Development and Implementation Group has been working with the Trauma and Orthopaedics Network. So they had a task and finish group where they looked at a pathway for carpal tunnel syndrome. So the policy group is linked into that and then reviewed that pathway and those changes, and then amended the policy to align with that pathway. And the intention is that the policy will sit alongside the pathway, so that it's clear how the policy should be implemented. So there are a couple of changes that are set out, predominantly in relation to the requirement for nerve conduction studies. So it was really just if the committee are happy to approve those policies as written, or if anyone has any specific queries.
Okay, thank you, Richard, for that comment in the chat. Thank you, Brent. Any questions or comments on either of those policies? Anthony Gardner.
Thanks, Chair. Brent, more than happy with the policies generally. It was just a question when the group looked at the carpal tunnel policy. Did they have any assessment of any potential impact on activity figures? Just recognising this is one of the evidence-based interventions that we've been concerned about in previous years, and worked hard to make sure that those numbers are kept to a reasonable minimum that would support clinical judgments on effectiveness of treatment. So is there anything from the pathway? I'm assuming it's positive in the sense that it's alignment with the actual pathway that's in place, that's likely to be in place within different systems.
Yeah, so that's certainly one of the consideration of the committee was whether there would be any impact on activity levels. In the discussions that we've had with the network, the feeling is that we wouldn't expect that it should have a significant impact in terms of activity. We are, however, with all of our policies, we'll be monitoring impact, and if it looks like there is a change in activity, then we will pick that up with the network and try and understand that change in activity. But we're not expecting a significant increase in activity by the amendments that are in the policy.
Thanks.
Okay, Andrew. Yes, Anthony. Sorry. Thank you. Okay, thank you, Brent, once again. So, colleagues, we're being asked to support the recommendations there from the Medicines Management Group. Are we happy to support those recommendations in those three policies? Yes, is that agreed?
Yes, right.
Okay, right. Thank you very much. Thank you. Thanks once again, Brent.
That's great. Thank you, Chair.
Cheers. Thank you. Okay, back to the agenda. So we're on to another subsection reports from subcommittees, 11, 12 and 13. Those reports have been circulated. We've had significant discussion about the CCG Transition Board and the Quality and Performance Subcommittee, so I'm not sure if we want to go into any detail, but if anyone wishes to raise anything, I'm happy to try and answer questions on the Transition Board, and I'm sure Catherine will on Quality and Performance. But we have in the middle there the Collaborative Commissioning Advisory Group, which we haven't had any discussion on. So I'll ask Peter if he just wants to comment on anything from that particular report. Peter.
Thank you, Roy. And as colleagues will have read, 3 programme updates in there in terms of primary care, elective care and women's and children's, and then 2 items for future consideration at this committee, one being around SEND investment and the second one being around the population health operating model.
Okay, thank you, Peter. That was quite short. Okay, so do I have any questions on those or any of the other 2 reports that are included? No? Okay, I think they are for information only, but I'll just check. Yes, they are. So they're just for noting. Okay, colleagues happy to note those 3 reports from the subcommittees? Yes? Good, thank you so much. Okay, we have then at item 14, questions received from the 15th of July 2021 meeting. The questions and answers are attached and have been circulated with the papers. Nothing other than to use those for information only. That's an information only item. So again, I'll move us on to, I think it's AOB. I've not been informed of any other business Does anybody else have any other business they'd like to raise at this present time? Anthony.
Yeah, thanks, Chair. Really a reflection on the meeting and the question, which perhaps links back into the terms of reference. We've had no financial update paper on today's agenda, and I don't recall one in recent meetings. Now, I know that we're looking quite considerably at financial position as part of the ICS work, and that's reported into the ICB board. But again, it reminded me, just reading the terms of reference, that the terms of reference do cover the financial and activity and finance activity and contracting position. And clearly the position, with my close down hat on, the financial position for CCGs will have a direct bearing at the end of this year into next year for the ICB. So I just wondered if there are any thoughts about an update. I'm not calling for papers to come to every single meeting, but if there's an opportunity for a position statement for CCG finance to come to a future meeting, please.
Okay, thanks, Anthony. I'll bring Andrew in a moment on that, but just to say that we are awaiting, I think, the financial guidance and the financial planning, which I think is coming out on September the 16th, which covers H2, which was Q2, Q3, Q4. I think when that financial planning guidance is received, we will be seeing more information about how CCGs will be able to respond to that guidance and the position for them going forward into Q3, Q4. Again, perhaps we need an update on H1, and I think again that might be required to come forward to a future meeting. Andrew, is it okay to bring you in on that?
Well, I'll just make a quick comment, and then if Gary wants to add, he's
Sure.
very welcome to do so. Roy, we can certainly have a look at that. Anthony, we obviously provide a system finance update at the ICS board. The information would be of similar interest, I think, to members of the committee, but that would be relatively easy to achieve. But let me just see if Gary wants to add.
Gary? Oh yeah, Gary, thank you.
Yeah, I mean, we do produce that information. I think the big issue for the CCGs is probably the extent to which they can hit some of the savings targets that have been set. I think that feels like it's a really big risk and an issue at the moment. And I forget who said it, but you know, well, it's you that said it actually, Roy, where we're up to in H1, I think is going to be an important milestone for us as a system. So these reports are put together for the ICS board, and it will be easy to pick out the CCG elements, both for the position of the CCGs, the run rates of the CCGs, and the savings programs of the CCGs is information that we collect and collate at the moment for the ICS board. So I think, as Andrew said, it would not be a difficult or burdensome process to be able to just make those reports available to here too.
That's helpful, Gary. Thank you, Paul.
Yeah, just to add to that, I think that's fine what Gary said. CCGs obviously are still reporting their own financial positions to their governing bodies, and there's things that we can't delegate to this committee as well. So I think Anthony's right. We can bring a summary of the CCG and the ICS position because that goes to various forums. But just to assure the committee as well that the financial responsibilities also go locally through CCG statutory bodies as well.
Okay, thanks, Paul. And I think it's important. I think that I talked about the finance planning, which is coming out next week. I think it's perhaps important that the H2 position is understood as well by this committee, because clearly that could have an impact on future CCG finance and the savings that has already been indicated by other speakers. So, Anthony, are you happy to accept that position?
Yeah, that's great. Thanks.
Yeah. Okay, sorry, Gary, you wanted to come back.
Yeah, just to say that we're putting together the scope for the plan at the moment, and it is looking like it's going to be a really tough second half of the year. So I do think it's entirely appropriate for this committee to have, you know, a bespoke briefing on that, and Carl and I can make sure that happens.
Okay, that's helpful, really helpful. Thanks, Gary. Thanks once again. Okay, thank you, Anthony, for raising that. Okay, back to the agenda, colleagues, and that was any other business. Don't think anyone else has indicated. I can't see anyone. Hands are up or nothing in the chat. So the next meeting of this committee is on Thursday, the 11th. Bear with me. Sorry, I've slipped there. Thursday, the 11th of November, 1 p.m. till 3 p.m. Again, it's an MS Teams meeting, as this one has been. So just remains for me to say, colleagues, and to members of the public who've joined with us, thank you for your input and discussions this afternoon. It's very much appreciated, and look forward to seeing you at a future meeting. Thanks once again.
Yeah.
Thank you, colleagues. Bye.
Thanks, Chair.
Thank you.
Thanks, Chair.
Thank you.